Thank you, Richard, and good evening, everybody. Thank you so much for joining us. We always look forward to our Webinar Wednesday series. And tonight we're here with you to bring you the 2022 reimbursement update on ENB, presented, as Richard said, from the lung health business. And I am pleased to share with you who our two guests will be this evening. They're Medtronic personnel. And first we have Chayna, Gaynor-Champion. And Chayna is a field reimbursement manager for the East area. She's located in Louisville, Kentucky, covers the East Coast, and she's been with Medtronic for nearly a year. She has clinical and health economic experience supporting customers in the medical device industry. And we also have Marie Gambeno. Marie is also a field reimbursement manager who resides in Denver, Colorado, and covers the west part of the United States. She's been with Medtronic for about 6 years now and has extensive experience in payer relations and expanding patient access to lung health technologies. Next slide. I wanted to just also mention to you that we have QR code here. As the directions state, you can aim your camera and save the information for a survey at the end. We'd love to get your feedback and ensure that we are able to take that feedback and make changes to our programs. We offer these programs every other month, and so look forward to hearing from you at the end of the program today. And as Richard mentioned, we love to get some Q&A and make this be interactive. So we'll look forward to hearing from you in the Q&A function or the chat function at the bottom of the screen. And with that, I'm going to turn it over to Chayna, who's going to kick off the program tonight. So again, thank you for being here.
All right. Well, thanks, Jody. Appreciate it. And just want to say good afternoon to our customers in the West, as well as good evening to our customers in the East. As Jody mentioned, I'm Chayna, Gaynor-Champion. I'm the Lung Health Field Reimbursement Manager for the eastern part of the United States. And I'm going to be covering the first half of this presentation, and then I'll be turning it over to Marie Gambeno, who's my teammate in the western part of the United States, who's going to finish out our presentation for the afternoon. But before we get started, I do have some disclaimer information we need to touch on, and that's just to say that today's presentation is for informational purposes only. It's not designed to provide clinical or legal advice, and the provider has the sole responsibility to determine medical necessity and to submit the appropriate coding and charges for the care that's been delivered. So this is our agenda for this afternoon. I'm going to be presenting the first half, which means I'm going to be talking to you a lot about the reimbursement tools and resources we have available on our team. I'm also going to do a short little reimbursement refresher, just talking about the components of reimbursement, as well as how payment differs across the various sites of care. And then we'll get into the 2022 CMS updates. From that point, I'm going to turn it over to Marie, and Marie's going to talk to you about complexity adjustments. She's going to talk to you about the payer landscape for ENB as it stands today. And then we'll get into some frequently asked questions. And after that, we're going to open it up for Q&A. And our main objective really today is to obviously familiarize you with the 2022 changes in reimbursement for ENB related procedures. We're mainly going to focus on hospital outpatient, but we're also going to briefly talk about the physician payment for 2022. And above all things today, the main thing is we just want to make sure you're aware of our reimbursement team, like who we are, how you can contact us, as well as the support, the tools, and the resources that we can provide that can help you minimize barriers and improve patient access to the ENB-related procedures. So just to level set, in case you're not familiar with the term ENB, ENB stands for Electromagnetic Navigation Bronchoscopy, and it's also referred to as computer-assisted image-guided navigation or navigation bronchoscopy, and I've even heard it's shortened to NavBronx. I hear that a lot. ENB is a very innovative technology that's used in conjunction with standard bronchoscopy, and it helps the physician because it helps him or her guide endoscopic tools or catheters within the pulmonary tract for sampling of pulmonary lesions that are often considered too small or too peripheral in the lung for a standard bronchoscopy. And I've heard EMB described as GPS for the lungs, which I think is a really good description, as it provides a visual roadmap of the lungs that the physician can follow in order to reach these smaller, more peripheral lung lesions. EMB can also aid in dye marking or fiducial marker placement within soft lung tissue. Now, Medtronic's EMB technology platform includes the first generation superDimension navigation system, and the newest EMB platform is called ILLUMISITE. In terms of field reimbursement support and partnership, there's a lot of hands-on support and resources we want to make you aware of. First and foremost of all is basic reimbursement support. So this means calling us or emailing us with your coding and billing questions, and we can provide, answers to most of those questions that you have. We also want to provide assistance with prior authorization and claims denials, and we can help you with the appeals process if needed. We can also provide claims reviews, to help you understand EMB reimbursement and your final payment. And, there's a lot of rules around reimbursement, especially around these kinds of procedures, and it can get really confusing. So it can be helpful to have another set of expert eyes help you in that review process. The reimbursement team also plays a very important role in developing tools and training resources you can use. And this includes reviewing and updating the annual reimbursement guides most of you are probably familiar with, and which, by the way, the 2022 billing and coding guides, as well as the complexity adjustment guide, should be ready in the next few weeks. And everyone that's on this call today will get a copy of those guides, as well as a link to our reimbursement website and a copy of this video presentation today. So along with the guides, we also love to do education and training with our customers. So, it can be as simple as a review of the billing and coding guide to more complex support, such as doing the claims review. And we can do the education in a lot of different formats. We can do it one-on-one, we do that a lot, or we can do it in a group setting via a virtual platform like Zoom or Microsoft Teams, whatever is going to work best for you. And most of our customers, they initially reach out to the local sales rep to connect with us, but you don't have to do that. You can contact us directly, and we're going to provide you our contact information at the end of this session. One of the big rocks, we try to move each and every year is improving payer coverage and expanding patient access for EMB. And there have been some huge gains in positive coverage decisions for EMB in the last 5 years, but there are still some payers who still consider EMB investigational and not medically necessary. And there's a lot of work involved with the gaining payer coverage. And, sometimes we're successful and sometimes we're not, but we keep trying every single year. And you, our customers, are so important in payer advocacy efforts. Now, Marie's going to talk more about this when she covers the current reimbursement landscape for EMB in her sections. Lastly, part of our role as a reimbursement manager is to deliver economic messaging. And so for our customers who need to build a business case to justify implementation or expansion of ILLUMISITE or one of our other lung health technologies, we can provide financial modeling which demonstrates the projected downstream revenue potential or revenue potential of investing in Medtronic lung health technology. These kinds of models are built and presented by the reimbursement team to financial decision makers, usually, who are within the hospital administration, who are responsible for purchasing decisions. And economic models are a really important way to communicate the value of our lung health technologies and help our customers understand the feasibility as well as the viability of EMB. As I already mentioned, we have several tangible resources available to help you navigate the EMB reimbursement landscape. And I'm just going to cover a few. This is not an exhaustive list. I've already mentioned the 2022 EMB billing and coding guide, which is going to be available in the next few weeks. I do want to mention that the coding included in the billing and coding guide are examples of procedures that may be completed with EMB. The rates listed in the guide are national averages that have been rounded, and they're based on the CMS hospital outpatient physician and ambulatory surgery center reimbursement. And because multiple procedures can be administered in the same patient encounter, the payment or the final payment may be subject to packaging rules, multiple procedure reduction, or complexity adjustment. Now, none of these billing rules are illustrated in the EMB billing and coding guide, but we just want to make sure you're aware of these rules, that they exist, and that they can impact your final payment. Along with the billing and coding guide, you're also going to receive the 2022 Complexity Adjustment Guide, which includes the code pairings that when you bill them together, they're going to qualify for a complexity adjustment, meaning that the payment will be made at the next highest paying APC. Now, this was really exciting news last year for EMB, as there are two code pairings that when they're billed together, it's going to bump the payment to the next highest paying APC. And the 2022 guide has been updated, and it's inclusive of all the qualifying code pairings. And if none of this sounds familiar to you, then you're in luck, because Marie's going to talk more about the complexity adjustment scenarios in her section. The next tool that we have is a patient selection tool, and this is a worksheet that you can use to help you document the medical necessity for the EMB procedure. So it includes the most common documentation requirements to support medical necessity, along with relevant CPT and ICD-10 coding. This is a really handy guide that you can use in the authorization or appeals process. The next document we have is the physician to payer checklist. And this is just a checklist that highlights talking points for physicians to consider when they're engaging with health plan medical directors in a peer-to-peer review for EMB. It's a great resource that can be used in order to plan for those kinds of peer-to-peer discussions. And lastly, we have our economic models, which I've already mentioned. We actually have 3 models available depending on the customer's needs and the technology under consideration. These models are customer specific, and what I mean by that is that the inputs and the reimbursements that we use in the model are specific to the hospital customer. The output of the model is financial information our customers can use to inform their decision-making about investing in or expanding use of our lung health technology. So there's lots and lots of good resources available. So please reach out to us, or send us your email in the chat box, and we can get these resources to you. We're here to help any way we can. All right. So before we get into the CMS payment updates, I just kind of want to set the stage and do a brief refresher on the components of reimbursement, as well as how Medicare reimbursement works across the different sites of care. So as many of you know, reimbursement is based on 3 elements: coding, coverage, and payment. And coding is the link between coverage and payment. It's that universal alphanumeric language that we use between payers and providers that describes diagnoses, medical services, procedures, drugs, devices, lab tests, supplies that have been provided to the patient. And these codes are used on claim forms and submitted to insurers to enable payment. So examples of coding systems we all know are CPT codes, our level 1 or level 2 HCPCS codes, the ICD-10 diagnosis codes, and the ICD-10 procedure codes. And related to all of this coding is the Medicare Severity Diagnosis Related Grouping, or the MSDRG classification system, which is used on the hospital inpatient side. Coverage refers to a payer's decision to provide program benefits for a specific product or service. So these are the health medical insurance coverage policies that are developed by healthcare insurers and describe what is covered and under what circumstances or criteria. Payment is the transfer of money from the payer to provider for the healthcare services provided. And this is the final step in the reimbursement process and is based on insurance coverage and coding of the services performed. So you can see how all 3 of these concepts are linked together. Now, when you consider the Medicare reimbursement systems across the various sites of care, there are certainly differences in payment systems by provider type. For example, on the hospital inpatient side, we've already talked about the MSDRG classification system. So this means that the hospital receives one comprehensive payment per inpatient stay, per patient per inpatient stay, under one MSDRG classification. On the outpatient side, we use ICD-10, CPT, and HCPCS Level 2 codes to report health services and supplies. And these codes are then translated into an APC, or an ambulatory payment classification, similar to MSDRG, in order to determine payment. On the ambulatory surgery center side, the surgery center receives a payment at a rate discounted from the hospital outpatient payment rate, and it's based on the idea that, or the assumption that, an ambulatory surgery center is more efficient and has lower costs than a hospital. Now, physicians receive payment based on relative value units, and these relative value units for the services provided account for the physician work, for practice expenses, and for malpractice insurance cost. The RVU value for the service is then multiplied by the Medicare conversion factor, which determines the physician payment. And our conversation today is going to mainly focus on the outpatient as well as the physician payment, because this is where the EMB procedures are performed on an outpatient basis. All right, so on to the 2022 CMS updates. So this slide here, this is a snapshot of our 2022 EMB billing and coding guide. And you'll see that the guide is organized by EMB related procedures as well as the associated provider payments. So up at the top here, we have our typical bronchoscopy codes that are billed with the EMB. We have our physician payment, ambulatory surgery center payment, as well as a hospital outpatient payment. Now, in general, for physicians this year, for 2022, the payment rate changed plus or minus 1% across all of the EMB related procedures. And I have to tell you, this is much better than we expected, as CMS had announced back in November to implement much larger cuts to physician payment in 2022. But these cuts are on hold right now, with payment reductions minimized. On the hospital outpatient side, the reimbursement for bronchoscopy procedures has increased approximately 1% to 2% nationally. Now, reimbursement for bronchoscopy procedures under CMS has shown steady growth year over year. And this is not one of the largest increases we've seen, but it's still an increase, and that's positive. So that's a good thing. And I do want to point out too on the guide that our CPT code for EMB, which is the 31627, you see here at the bottom, as you can see on this illustration, there's no separate hospital reimbursement for EMB. It's an add-on code, meaning that it's performed in conjunction with another primary service by the same practitioner. And this is really important to remember as we move along in the presentation and Marie starts talking about and discussing complexity adjustments and why it's so important to document and bill for everything provided, even though no payment is expected. So I don't want to steal Marie's thunder, but I'm going to turn it over to Marie so she can dive into comprehensive APCs, into the complexity adjustments, as well as some important coding scenarios where it is essential to bill for 31627 if it's been performed. So Marie, I'm going to hand it over to you. And if there's any questions, please put those in the chat box and we'll answer them at the end of the presentation.
Great, thanks, Chayna. Okay, so as Chayna mentioned, this next section, we're going to go ahead and review the highlights and the recent history of the bronchoscopy payments and how the 2021 complexity adjustments impact hospital outpatient payments. So before we dive into the complexity adjustment refresher piece, I do want to remind everyone what APCs are. So APCs, or ambulatory payment classifications, are the United States government's method of paying for facility outpatient services for the Medicare program. So APCs are an outpatient prospective payment system that's applicable only to hospitals. So this particular slide dives into the progression of the comprehensive APC payment packaging policy that became effective back in 2015, if you'll remember. So this replaced the multiple procedure payment reduction rule for many surgical procedures, including bronchoscopy. So the multiple procedure payment reduction, or the MPPR, means that if a healthcare provider performs performs multiple procedures during a single patient encounter, Medicare, as well as several other commercial payers, typically will reimburse fully for the highest valued procedure, and then the secondary codes were paid at that 50% reduced rate. So back in 2017, all the bronchoscopy codes were reimbursed under the comprehensive APC system. So this designates a primary procedure with adjunctive and secondary services packaged into the payment for the primary procedure. Now, E&B and TTNA are also paid under this comprehensive APC system in the same way that bronchoscopies and biopsies are. So using prior claims data, CMS ranks these procedures by the mean cost of the procedure. The higher the mean cost, the higher the rank, and the higher ranking code is the primary code that receives full payment. So one example is that prior to 2017, when billing for a bronchial brushing, fiducial marker placement, E&B, and a transbronchial biopsy, the fiducial marker placement would be paid in full, and the remaining codes outside of E&B would be paid at 50%. Now remember, E&B is a packaged code for the hospital outpatient. So under that comprehensive APC payment system, only the fiducial marker placement code would be paid at 100% because it is the highest ranking code. Everything else is packaged into that one payment. I'm sure many of you remember the impact that was felt moving bronchoscopy to the comprehensive APC system and how the hospital outpatient reimbursement was affected. And in some cases, it was affected substantially. CMS does recognize that the comprehensive APC system may not accurately reflect total costs associated with multiple procedures. And in 2015, they finalized the comprehensive APC complexity adjustment policy. So the complexity adjustments were implemented by CMS to provide for a payment adjustment when two or more high-cost procedures are performed and paid under the Medicare's hospital outpatient comprehensive APC system. So in order to qualify these claims with certain code combinations, they must meet specific thresholds for both cost and frequency. When these specific thresholds are met, the code combinations qualify for reassignment to the next highest paying APC. Now, if only one of these thresholds are met, the code combinations will not apply. So if you'll remember, there was exciting news. I know Chayna had mentioned that too, for 2021 regarding payment when you do navigation with a bronchoscopy. So for the past year, when E&B was billed with either a bronchoscopy with brushing or bronchoscopy with a lavage, the code pairing qualified for a complexity adjustment, and it was reimbursable at that next highest paying APC. So I want to point out again that 31627 is a packaged code, so meaning there's no separate reimbursement when 31627 is billed under Medicare. So payment now more than doubles on the national average when bronchoscopy with brushing or bronchoscopy with lavage are performed and billed in conjunction with E&B. So if you're not billing for 31627 when it's being performed, this is actually a perfect example of money that would be left on the table. So this next scenario kind of illustrates when a bronchoscopy with the brushing, transbronchial needle biopsy, and EVIS are performed in conjunction with E&B. There's two sets of code pairings that would qualify under or qualify for a complexity adjustment in this example. As we reviewed, 31623 or a bronchoscopy with brushing is billed in conjunction with 31627. The code pairing does qualify for payment at the next highest paying APC. However, in this specific example, the 31629, which is a transbronchial needle biopsy, billed in conjunction with EVIS, also qualifies for the complexity adjustment and payment at the next highest paying APC. So since 31629 is the highest ranking code out of these two scenarios, the complexity adjustment would be adjusted off of the 31629 and 31653 code pairing. So basically, in other words, you would not receive an adjustment off of, you basically won't receive a double complexity adjustment. It's based off of that highest rank. Okay, another scenario to review. If both bronchoscopy and brushing and lavage are performed in conjunction with E&B, so both 31623 and 31624 are billed with 31627, qualify under the complexity adjustment. But in this example, 31623 is the highest ranking code between them. So that is the code that is complexity adjusted in this example. So as we just reviewed, proper billing practices can have a substantial impact on future payment. There's several factors critical to determining future reimbursement, and one being the importance of accurate cost reporting. All data needs to be captured as facilities submit annually all costs surrounding their procedure, and this does include personnel costs. That reporting is reconciled by CMS and a lump payment is made. So if all costs are not accurately captured and reported on, it does impact future reimbursement rates. So the eligibility for complexity adjustment is also reviewed annually. And it's critical that all services rendered are billed for. I've had many conversations over the years regarding E&B not being separately reimbursable, and that 31627 is often not billed as providers know it's a package code under CMS. Some commercial payers still consider E&B to be experimental and investigational as well. This actually hurts our efforts in the long run when we're trying to advocate for either an increased payment or positive payer coverage. We've been educating accounts on the importance of billing for E&B in addition to their other bronchoscopy services, even if payment is not expected. With E&B now meeting the cost and frequency thresholds for complexity adjustments, billing for a bronchoscopy with a brushing and lavage will now trigger the complexity adjustment, reimbursing at the next highest paying APC. Correct billing is also crucial when advocating for coverage of new technology. Submitting a code for authorization, even when you know it's not going to be approved or paid on, is part of the overall payer advocacy process. Payers are more likely to evaluate for a change in coverage policy if they've received requests for a particular code or a specific technology. I've spent several years working for a large health plan and sat on their new technology committee that met monthly. And the first point that was always discussed was utilization and who was asking for the technology. If no one was asking, it was not a priority for review. These reviews are full of technology requests, and the ones that had the most, I guess, noise, for lack of a better term, were the ones that were reviewed. So when I've been able to meet with medical directors in the past to discuss policy review, the first thing they do is they can pull up a report on their computer and show what utilization is or what requests have come in for that specific code. It's a challenge when the report is pulled and no authorization requests or denials have come through because you basically have little to no leverage. So I can't stress enough how important it is to keep those authorization requests coming, even as especially as we try to work through and obtain positive payer coverage. Okay, so next we want to highlight where we are today in terms of commercial payer coverage. So where are we today? Obtaining commercial payer coverage for E&B, it has been a challenge over the years, but we do feel like we have turned a corner in recent years. A common misconception that we often hear is that since E&B is considered a standard of care today, commercial plans should be covering E&B. The reality is that these plans have specific criteria that they're looking for in order to reconsider their experimental investigational status. So we've had commercial payers overturn their negative E&B policies as a result of the published one-year Navigate study results, and others that have kept the negative status, stating that while the Navigate study attempts to provide a real-world practical design, the results of the study are limited by the absence of a protocolized approach. I have another payer that I worked on, Regents Blue Cross Blue Shield in the Pacific Northwest. They agreed that there is clinical efficacy, but decided they didn't have the ability to expand their prior authorization bandwidth, so decided not to overturn their negative policy at that time. And they mentioned that they would be monitoring requests that came in for future review. So that's another example of why it's critical to put those authorization requests through, even though you know it's going to be denied, because they do track that. We've had 18 commercial payers overturn their negative E&B policies from about the summer of 2019 to mid-2020, including the vast majority of the Blue Cross Blue Shield plans. As you can see, we saw a nice increase in coverage growth over the past few years. Now, COVID did turn everyone's world upside down, so it wasn't too surprising that the payer advocacy seemed to kind of halt mid-year 2020. We have ramped up payer advocacy efforts in the past several months, and will continue moving forward until E&B is covered across the country. So even though we've made great strides in obtaining coverage for E&B, we definitely still have gaps in coverage that we're working diligently to address. So those of you that are in an Anthem state or any of the other areas highlighted on this map, you understand how challenging it can be to try to obtain E&B coverage for your patients. So currently the top payers that we're continuing to target include Anthem, Aetna, which is a national policy, Regents, Blue Cross Blue Shield, Premera, and UPMC. We previously worked advocacy on MedMutual of Ohio, Regents, and Anthem in recent years, and some of you may have been a part of that effort. With those specific payers, we haven't received any policy change as of yet after their reviews, but actually just found out yesterday for MedMutual in Ohio that they have removed E&B from their experimental investigational table as of 12/2/2021. So this is actually great news because we've been working on this payer for about 18 months. Their final rationale for removing the experimental investigational status is that they've reviewed the Milliman criteria to guide their coverage decisions. Now this is good, this is great news because MedMutual is a top 25 commercial payer. So this positive payer outcome is significant as we try to obtain national payer coverage. So as we move forward in our additional efforts, we may be reaching out to you to gauge your willingness to participate in advocacy of a specific payer impacting your account. These truly are team efforts and the best outcomes come from participation from all phases. So a great example would be for a payer campaign we ran for Blue Cross Blue Shield of Alabama a couple of years ago. So I met with our KOL as well as several other supporting physicians in order to secure support and ensure their understanding of what support may be needed moving forward. So these physicians all added their names to the letter submitted to this payer asking for a clinical and policy review. If your name and contact information is included on the payer policy review request, the plan can reach out to you with any questions. So I did make that clear. Blue Cross Blue Shield of Alabama actually did reach out to our KOL directly to set up a WebEx in order to do a technology review and to answer some follow-up questions that their policy review team had. During that conversation, the clinical was further discussed and the subsequent questions that this plan had were all answered by our KOL. So this was actually a really great example of a team advocacy effort because having Blue Cross Blue Shield of Alabama change the policy status for E&B helped us actually gain positive coverage for Blue Cross Blue Shield of Louisiana shortly after. It opened the floodgates and then really providing positive payer outcomes in the southern part of that country. So working on this payer advocacy is time consuming and it doesn't always go in our favor, but we keep trying as we know it's necessary in order for our patients to have access to E&B. So this next section, I'm just going to go ahead and highlight some of the frequently asked questions regarding coverage, coding, and payment for E&B that Shannon and I have received over the past year. So my biller said we should not bill for 31627 because it is a bundled code. Is this correct? 31627 is a packaged code, not a bundled code, and should be billed separately. Bundling is a coding concept, while packaging is a payment concept. So there are important differences between packaged services and bundled services. Unfortunately, this term is often used interchangeably and can result in incorrect coding practices and can result in potential lost revenue for the organization as well. So the bundling coding concept combines two or more codes into one, and doing so allows them to replace two codes with one overarching code and pay the provider for the amount allowed under the more dominant code. Packaging is a reimbursement term, so it refers to the practice of making a single payment that includes payment for a significant procedure as well as the minor ancillary services associated with the procedure. CMS frequently uses this term to define the services for which it will not provide separate payment. Even though CMS may not provide payment, however, the code for these services should still be reported on the claim form unless it's contraindicated by CPT coding guidelines or by the correct coding initiative edits. It's especially important that package services be listed so that CMS can collect accurate data about hospitals' costs. In addition, not all payers follow Medicare payment policies, and they may provide additional payments in situations where CMS does not. So the complexity adjustment changes for 2021 is a perfect example of how proper billing practices can change your reimbursement landscape. Can we bill separately for a bronchoscope, adapter, or needle or brush? And if so, what C codes can be used? So unfortunately, there are no assigned HCPCS codes for any of the disposables related to E&B. There's actually a note on the front of the 2022 billing guide that you'll receive shortly that has this caveat on there as well, but there is no code assigned for any of these disposables. Our patient required an additional CT scan after the initial scan due to a change in their medical history. United Healthcare approved the initial scan but denied the subsequent scan. Is there any recourse? So the quickest and most effective method to request an appeal is for the physician to do a peer-to-peer review with the health plan medical director. And that's needed in order to explain the clinical rationale for that repeat CT scan. So the CT scan is necessary to assist the minimally invasive E&B procedure in evaluating suspicious lung nodules. So prior to the procedure, the patient may need another repeat CT scan for reasons such as the raw data format may not be available. There may be a referral patient, so they don't have any data. There may be too much time that has elapsed since the original CT scan, or the physician may need to document a clinical change. So this question actually comes up semi-regularly. And when an account that is experiencing a denial calls, I always recommend that the physician picks up the phone and has a conversation with the health plan's medical director. When these additional scans are billed, they will be denied as it appears it's a duplicate claim. So once a clinical need is communicated to a peer during that peer-to-peer session, the denial is usually overturned. So our physician documented both a lung biopsy, 31628, and a needle aspiration, which is 31629, during the navigation bronchoscopy. Should we bill 31627 2 times or just once? E&B or 31627 should be billed once. So many bronchoscopy codes are considered to be bilateral procedures. So that would include that CPT code range of 31622 to 31627. And it would not be reported with a modifier 50 or a bilateral procedure. We realize a bronchoscopy is inherently bilateral. However, when a bronchoscopy is only performed on one side, would it be appropriate to append either a modifier RT or LT to the specific bronchoscopy code? It would not be appropriate to append RT or LT to the CPT code when the bronchoscopy is performed on one side only. So as this question states, bronchoscopy codes are considered to be bilateral procedures, and we'll use that same range, 31622 to 27. A bronchoscopy is not limited to the extent of the bronchi that is actually looked at, and therefore it's still considered to be inherently bilateral. So it would be inappropriate to append an LT or a left side or RT, right side, modifier to the CPT code when a bronchoscopy is performed on only one side. What code can be used to capture the mapping that is performed prior to the E&B procedure? We are already billing 31627 on the day of the bronchoscopy. So according to the AMA, the mapping is included in the description for 31627. It reads bronchoscopy, rigid or flexible, including fluoroscopic guidance when performed with computer-assisted image-guided navigation. So CPT code 31627 describes bronchoscopy with computer-assisted image-guided navigation, also referred to as navigational bronchoscopy. So navigational bronchoscopy is a three-dimensional virtual roadmap. Enables a physician to maneuver through multiple branches of a bronchial tree to reach targeted lesions in distal regions of the lung. It is designed to be used with a standard bronchoscope to facilitate obtaining tissue samples and placing radiosurgical or dye markers. So to close, I do want to reiterate that Chayna and I are here to provide reimbursement support to you and to participate in any partnership opportunities that can help reduce any barriers to reimbursement. They include, but are not limited to being a reimbursement matter expert, coding and payment questions, clarification, walking through specific scenarios and developing game plans moving forward, We can communicate year-to-year changes and opportunities and what additional resources would be helpful to you. So the ultimate goal is to try to remove any barriers to access for the EMB technology. We also work to create healthcare economic models, and this includes building and presenting economic models based off of your specific business needs and data points. We also assist with claim denials, and this goes beyond providing just an appeal letter or a peer-to-peer resource. We can walk through claims reviews and collaborate if appropriate when some of these circumstances have the potential to become future payer advocacy efforts. One example is a claims review we did with an account in Florida, and they felt they were losing money on ENB, but after reviewing a series of claims during a claims review, we were able to see, what was billed and what was paid, and then we learned that they weren't capturing all services. This was an example where they weren't, they definitely left money on the table just by not going through and making sure that everything was captured. Lost revenue can be substantial if it's over a period of time, or it's substantial depending on the number of patients. And if it's caught early enough, there's time to go back and rebill, and that's what this specific account was able to do. We also provide training and education regarding not only coding coverage and payment, but detailing specific changes to reimbursement on various levels. So this is especially helpful with new accounts or accounts that have been a little quiet. Walking through the proper coding and billing practices up front and doing a claims review, after a set number of claims to make sure that everything is done correctly. Helps to mitigate any issues that are happening or that can potentially happen on the back end. Any of these conversations can be done in a group setting as well as one-on-one training, as Chayna mentioned, whichever format is better for the customer. So our contact information is included on this slide, so please reach out to either Chayna or myself for a follow-up conversation, and so that we can make sure that you're set up for success as you navigate your reimbursement landscape for 2022. And with that, we can open it up to questions, Jody.
Sure. Yeah, absolutely. And we have a question here. So the first question I have for you, Maria, is should we be billing for the radial EBUS for peripheral nodules?
Are we talking 31654? Can you repeat the question?
If you can take yourself. Oh, here, just a minute. She just responded. Yes.
Okay.
The question would be, should we also be billing for the radial EBUS for peripheral nodules?
If they're performing radial EBUS, they should be billing for radial EBUS. Is there a specific coding scenario? Because that's something we could, if there's specific coding questions or like scenarios, we can also put those together. Because I'm thinking if maybe Jody, if one account has that, then maybe others would too. And I'm happy to put those together too, because some of those will have specific billing rules as far as what gets paid in a coding combination. I'm not sure if it's part of additional codes.
Okay, we'll see if more information comes, but if not, I've got another question for you.
Okay.
How do I get assistance for a claims denial, and what does that appeal process look like?
So if you have a claims denial that you need assistance with, definitely reach out to Chayna or myself, and either one of us can help you. We do have an appeal template, but actually my recommendation would be to use it's basically a physician to payer template that I know Chayna had touched on. What that does is it's a template that walks through specific information regarding that patient's clinical situation. So when you actually have a conversation with the medical director at the payer, you have all of that information handy. But keep in mind that a lot of these payers, their medical directors are not pulmonologists. They don't live in this space. So the more detail that's given, the better the chance of maybe having, a different outcome after that appeal. So that would be my recommendation, but I would always, encourage them to reach out to us and we can kind of talk through what the situation is. I know some of the advocacy that we've kind of worked on to get policies changed stemmed from denials that have come in and that we've kind of worked through to see, what can we do moving forward? Because if one account is having it, others are going to have that as well.
Wonderful. And it looks like the person who asked the question in your chat box there, Marie, if you have accessibility to that, gave a little bit further explanation for you if you want to take a look at that. She states, I sometimes do EBUS and ENB. So I will do transbronch EBUS with needle sampling, ENB with radial EBUS. EBUS with needle sampling, ENB with radial EBUS, yeah.
Yeah, let's take this one, Jody. I just want to map it all out and put the codes together because certain codes will be paid and then certain ones won't. So we just want to make sure that we get all of that correct and we can send that out to everybody.
Perfect. We will do that. I have another question, Marie. So wanting some clarification, if we sample multiple nodules using separate needles and biopsy forceps and possibly using different EWCs, is this a bundle or billed separately?
If you're sampling
with multiple nodules using, sounds like multiple tools, right? Needles and biopsy forceps, and possibly using a different EWC, is that a bundle or is that all billed separately?
So what is an EWC? Can we get clarification on that?
Like yeah, that's the extended working channel that the tools go through that's attached to, in our case, you know, the ILLUMISITE tower.
Okay. I think that's
basically wondering, yeah, go for it. I'm sorry, I don't want to interrupt your train of thought.
No. I was going to say, let me check on that. I believe that they're done together, but I just want to go through and I want to put it all on paper so that I can get that out to everybody. I just think that it's clearer that way, just so we can make sure that we have all of that information correct with the different coding scenarios, if that would be okay.
Sure, absolutely. I have another question. Can we help with the claims review to validate that we are billing correctly for ENB related procedures?
Yes, so that's definitely an instance where, you know, we would want you to reach out to Chayna or myself to walk through basically making sure that you are comfortable with the coding that should be used and when to use that. We also go through, and I know especially for our new accounts or accounts that are having issues, we'll kind of go back and do a claims review with them. So they'll pull their claims information depending on, you know, what the comfort level is and what needs or what they want to have discussed. But we can kind of walk through actually and look at what's billed and what's paid, and then go through and make sure that each one is done correctly. You know, if you want to take, you know, maybe your first 5, or if you want to go back the past few months and see if that's something that you could look at. It's definitely something that we are able to assist with. It's important to do that when, you know, either up front or kind of, you don't want to wait too long, I guess is what I'm trying to say, because they do have, you know, filing deadlines. And if there's money that can be recouped, we want to be able to go back and rebill for that money. I know in the claims reviews that I've done over the past couple of years, we've always, you know, found errors, and that's, you know, usually why, if they're saying, you know, we're not making any money or we're losing money on ENB, it's because everything is not accounted for. So you have to go through and, you know, put all of your coding, all your codes basically that you're doing, you want to go ahead and bill. It doesn't mean you're going to be paid on that, but you want to bill for them. So we just want to make sure that everything's captured, but that is kind of a claim by claim walkthrough. So we can certainly help with that.
Okay, great, thank you. Last question that I have is, are there any best practices that you can share in billing for ENB procedures? And could our office be trained or retrained if needed?
Sure. I mean, honestly, the best thing that I would say, especially if you're a new account or an account that hasn't done a lot of these procedures, is to reach out to us just so we can have a conversation. And I know everyone is busy and they don't always have the time, but I think, you know, having us have conversations with the right people up front saves a lot of headache on the back end. So we'll go through and make sure, you know, they understand the coding, they understand what complexity adjustments are, they understand, you know, what payers look like in their area. So we're not billing for, you know, we're not billing Anthem for a patient when Anthem doesn't cover your state. You know, there's all kinds of different caveats that we, you know, can educate the account on. So I would say that that's definitely, to me, kind of top of mind and would be the most important thing to do. We've also got our resources. So we have our billing guides, we have our complexity guides. They've got all of the codes that are associated with our technology, and it doesn't have the billing rules included on there. So it doesn't account for, multiple endoscopy or multiple procedure rules. And that's kind of where, we can come in and educate on what that looks like. But it's always good to have those conversations up front if possible before, something happens on the back end and then you're going through and trying to, fix rather than getting everybody started on the right foot initially.
Wonderful. Thank you so much. Well, I don't see any other questions here in front of me. I know you all know the drill as to how to do this, so I think we will take that as you're good to go. I just want to thank Marie and Chayna for their time today. Certainly, I know we're going to be sending you out some information here on this deck, as well as the recording will become available to you shortly. You can take a listen, but make sure to reach to your Medtronic account managers if you need assistance with this. We definitely are willing and wanting to get out and help with training any way that we can, and look forward to being a great resource for you in this area. So thanks again, Marie and Chayna, and everybody have a great evening. Appreciate your participation tonight.
Okay, great. And I'll look for those questions, Jody, and we'll get those handled.
Perfect.
Okay.
Thanks, everybody.
Thank you.